it's a combination device, because of the suction um, um, uh, on it, it tends to actively decompress, or is thought to. So it's not just purely a thumper device. But the problem is, you can see that both arms get in the way, taking a patient to cath lab for imaging, angiograms and stuff. And then, there's other ways which you can use active decompression devices with an impedance threshold valve. This is something I studied during my FCAM, FRCAM at the time. And again, all these devices are meant to, they come in to make it better, make the more effective, but in fact haven't shown outcome differences. And their main uses really are to make CPR more convenient. But they are costly as well. So what's the ultimate goal of CPR is to achieve critical perfusion of vital organs while you can find a reversible cause or defibrillate the heart. So, if you're maintaining critical perfusion, and and also coronary perfusion pressure, because if you can perfuse the coronary arteries of the heart, the theory is that you can defibrillate it back into a normal rhythm more successfully. But the thing is, nowadays, there's people think that both mechanisms, the cardiac and the thoracic, contribute. And a single theory is unlikely to fully explain uh, what happens. Uh, the problem is, early on, it's thought that early on, if progesterone has, the biochemical change move out of cells and things, then the heart becomes much less effective. And it may just be that the pump is what's working. So that's what people are thinking. It's very hard to prove one way or another. Body habitus, different types of compression forces, rates, the airway ventilation related issues, and also the delay. So predominant, and I put them mainly done in the 80s, if you can see. And in the 90s, most of them now have supported the cardiac pump, mainly because they're using more circumstantial evidence as actual visualizing the heart, and they think that the cardiac compression is a significant mechanism. And I'll come to the so I'll go on to echocardiography as where that comes in, and where it comes in is we're talking about echocardiography. It will obviously identify patients with poor prognosis, i.e., those with asystole and cardiac standstill. So those guys, for a period, if they've had that for a period, the chances of them reversible cause. And again, sometimes what can happen is, and an echocardiogram can identify that, and you can go on and defibrillate. Or when I say echocardiogram, I just mean a point of care ultrasound, so off the heart. So I'm not actually talking for echocardiogram in that sense. But then echocardiogram is very useful for obstructive pathologies in particular. So the 4H's or 5H's and 5T's, depending on which number you use, but particularly when it's massive pulmonary embolism, a cardiac tamponade, or tension pneumothoraces. And also, as I think one of the ladies on the sepsis were talking about, hypovolemia can be diagnosed quite easily with cardiac echo, and also of the vascular system. And obviously the problem with normal echocardiography is it as interruption to chest compressions, which is a bad thing. So the idea is that, okay, and then observe it or watch it later on as we're as we continue chest compressions. But the problem is, again, the other problem is getting views externally can be quite difficult because we know that chest compressions go on, and also body habitus can make it difficult to get views. So the main advantages of transits visual echo are, and the diagnostic role is the same, and these are endorsed by AHA ILCOR, so there isn't really that much debate about that in my view. But the thing is, on the top bit, the enhancing CPR quality, because what it is, if you put in a transit visual echo, you can continue chest compressions just as normal, and also, if you do believe, and if, like I do, in the heart pump theory, cardiac pump theory, then you can actually look at chest compression and see what effect it's actually having. Now, this is really interesting because I mean, we ran a course on echocardiography recently, a workshop, and and we had some experienced physicians, ER doctors, and we were like, okay, let's do an echocardiogram, and we had volunteers, and they couldn't really find the good views because the volunteer we had was quite slim. He was a Bengali guy, porter or whatever, and his heart orientation was much more vertical. So his apex wasn't where you would expect it. And this is what one of the points I'm going to make is that everybody's slightly different, and doing compressions in the exact same way is unlikely to get the optimum effect. And I'll come to that in a minute. But the problem, obviously, limitations of transvascular echo is the probe. It's a separate probe. You need to get that. I mean, the actual screen on other ultrasound machines is probably the same. Obviously, the patient has to be intubated. And then this is also important with it's more people, because the team leader role has to be separate from the person doing the echocardiogram. They have to communicate, but it can't be the same person, ideally. And obviously, to do these sort of quote unquote invasive procedures, you need buy-in from the institution, and you need higher level of interpretation skills. Not everybody's comfortable with this skill yet, but I think I personally think that it should be something we should be part of our competencies eventually, and I'll come to it why. And the complications can happen. They're very low risk. As you can see, they're less than 0.1% overall. But the problem is pre-existing like or whatever. And I'm just going to show a quick study, which is and 9 of the patients actually there was either left ventricle outflow tract, making it worse by compressing. And otherwise, in a few of them, it was ineffective. So only 3 patients, was there a good compression without the guidance of the echocardiogram or echocardiographer. And none of them, these patients, or almost none of them, had a brachial pulse. 16 of the 19 didn't have one. But after adjustment, you could see that the compression had improved significantly, and the pulse. You could feel a brachial pulse in all of the patients. Though there was some good outflow. Now, this didn't necessarily, the study was too small to show an impact on survival, but what it did show is that you can actually guide your CPR much better with and chest compressions also. A single mode of compressions isn't always the right answer. So you need to be able to adapt a little bit if you're not getting the right, output. And that's something that we're not doing, I think, in my personal view. And you can see, though, it's a big team you need. So you need an echocardiographer, the lady who's in B. And then you need, and this is a big team for a reason, because other than having all the people who are supporting the CPR, you also have ENF, who are the ECMO team. So, if you're going to do eCPR, then, guiding while they're getting cannulations and stuff, then definitely echocardiogram may be useful in optimizing chest compressions and output. So just to mention, I mentioned competency and stuff. So this guy Philippe Terran is the first author of this review article, and he runs a whole bunch of courses on doing exactly this. He thinks this teachable to emergency physicians, and you can see most of these are in big conferences. So there was one in Montreal just before ISIM. There's one before ASAP, American College. There's another one coming up in September, just before USIM. So these are associated with big conferences where he's teaching this skill. But and this is the problem. The problem is that if you look at it, the reason we're talking about this is that the overall out of hospital cardiac arrest survival is quite low. So it's well below usually 10%. For example, Sweden, which is quite an advanced country with a high CPR rate, it was only like it improved from 5.7% to 10% over and the US is the same, similar. Although it's better for in-hospital cardiac arrest, which is a bit counterintuitive because people in hospital are sicker. So you think that these guys, if they have a cardiac arrest, they do poorly. But overall, it's up to 22% survival in hospital. But what that shows to me is that it's all about time. In hospital, we are trained, we can recognize quickly, the team shows up. Out of hospital, these things don't happen that quickly. Now, this is interesting because this is from Minnesota, and I've put this picture here on purpose on the top left, which they actually have a reunion, a patient reunion of see that when you look at this many people getting together in a room, and this is not all of them, and these are people who are essentially dead. So you realize that having a good program and high survival rate is very important. They could easily be productive members of society or their families. So what happens here? And they showed in their group of 160 patients, you can see that the functional survival rate was about 40% down here. Yeah. So after they've excluded a few patients, but even if you don't exclude the patients that were excluded, some of them, and then it's even up to 30%, so still very, very good. But they just couldn't sustain their rhythm. But even with that, it's more than 30%. So where do I think this fits in? The echo and the ECMO. ECMO is, I think that's fairly standard now. It's not something that's it's a must, but certainly if you can provide that standard of care, then I think the newest guidelines will show that then you should consider it. And I think there's a big trial going on they've stopped recruiting in Holland. They've done it over 3 years for pre-hospital ECMO, and they will come up with their results, and they will show. So hopefully it's very interesting to see what they actually show as far as survival in a country like Holland. So what I show is, okay, so for me, the most important bit is collapse and early recognition and good basic life support and defibrillation. And then, obviously you immediately get either your ROSC, and that's fine, you get good care, or you should be getting good care. Or if you haven't had ROSC, then you need to look at certain criteria, which are in the blue, in the green, and consider putting in cannula for ECMO. But in this period between ALS and your next level is what this comes in. That's where you need to really optimize perfusion. If they fit the criteria, and you exclude all the reversible causes, and the best tool you have to do this is actually, or one of the tools, I won't say the only one, but I think the best tool is a transesophageal echo. Yeah. But I don't want to sort of bamboozle everybody with, high-tech stuff, ECMO and all that stuff. I mean, the basics are still very important, or the most important. And, this is, if you recognize Cliff Reed, one of my gurus, this was at a conference earlier this year in Spain. And what he was showing is that ventilation is still very important, because if you look for the first 120 seconds or so, 180 seconds, 2 or 3 minutes, the saturations remain well preserved, even without any ventilation. Yeah, it's only after that that you start dropping your saturation. And even with expired air ventilation, you can maintain some saturations, but if you don't give any, they drop very quickly afterwards. So you do need to, still, I know compression only CPR is a thing, but we do need to think about a good ventilation and good compressions. Now, obviously, as far as compression, it should be adequate. The depth, the rate, the excellent recoil, and minimizing interruptions are still the key. But I think my own personal view is that and I'll talk about this in the next couple of slides, as far as where my technological solution to some of this is that in an out of hospital setting, time to recognition and activation are the key thing. Now, bystander CPR is a great thing. I mean, if you can teach all of your population and they're all keen to, do chest compressions, that's great. In the UAE, we've got a Good Samaritan law now, but still the responder CPR rate's very low. I think, my own personal preference is to have a whole bunch of first responders in the community who are trained, supported, motivated, and activated. Okay, you can have the bystander, but I don't think that's going to be and who have access to AEDs. So, and one solution for me, I mean, this is a study protocol that for a study in Victoria in Australia. It's called FIRST protocol by the ambulance service, and this they use a special AED